Because this is our last session of the 2025 calendar year. This is obviously our Center for Healthcare Policy and Research seminar, and I think we emailed you about this, Dr. Mayberry, but we have a real great mix of people who attend this seminar. We have students who take a seminar in public health, we have residents and fellows, early stage faculty, and then a lot of our staff. So it's a real mixed group. Oh, and also continuing medical education, which Bill just put in the chat. So we have this every week on Wednesdays, our last one for that calendar year, and we cover a variety of topics: policy, clinic embedded interventions, community-based research, and others, anything in the applied research and policy practice space. So your talk and our guest today, Dr. Lindsay Mayberry, fits perfectly into our seminar series, and we are so lucky and fortunate to have her join us from Vanderbilt University in Tennessee. So I'm just going to briefly introduce you. Even though you have many accolades, I'll try to be brief so you have plenty of time for your presentation. But Dr. Mayberry is an associate professor at Vanderbilt, both in medicine and in biomedical informatics, and is the director of the Center for Health Behavior and Health Education. So she has a background in psychology, and she does a lot of family and patient-centered digital intervention work, and specifically in diabetes, which is where I have crossed paths with her. And so I think today she's going to share some of her recent research with her, which I think aligns with a lot of our applied interests in our center. Thank you so much for joining us, Lindsay. Take it away.
Thank you so much for having me. I'm delighted to be here today. I'm really excited about the diversity in the group because this talk speaks to multiple different aspects of this issue, and so it's fun to have different perspectives. So I will see if I can advance my slides here. So I don't have anything to disclose. If you're interested in the Center for Health Behavior, I encourage you to visit our website. If you don't want to write all this down, if you just put in VUMC Center for Health Behavior, it will pop up. So who am I? I use these terms to describe myself. I say I'm a family and community psychologist. I also am a behavioral and social scientist, and I'm a behavioral interventionist. And so my passion starts from the idea of how do we use social contexts to improve health behaviors. But I have sort of three passions. One is about disparities, which has to do with access and justice issues. The other, as other ones I've mentioned, which are behavior and family and community contexts. And one of the things that I learned pretty early in my career is that what sits right at the intersection of those spheres is technology. And so I have been designing and evaluating technology-delivered interventions, and by virtue of doing that work, have been pulled into broader conversations about how we design technology to reach folks at risk for poor outcomes. And I have also just found myself sort of fighting a battle. Somebody keeps calling me repeatedly on Teams, I apologize. I've been fighting a little bit of a battle on the text messaging front with institutions. And so I'm going to talk to you about all of those things today. So I'm going to give you some sort of big picture to sort of frame our conversation, talk to you about why text messaging is such a thing for me, give you some examples of some successful texting solutions, talk to you about roadblocks and solutions that we might put in place sort of broadly with policy and the way that we do research in healthcare, and then talk a little bit about how to do digital tool development well. So my presentation objectives, which I always love being asked for CME, because it makes you think about what are people actually getting from this talk, are that hopefully you'll be able to articulate the assets of basic mobile phone technology as compared with other digital tools, identify roadblocks and potential solutions to designing solutions with text messaging, and identify some successful approaches to user-centered design and digital tool development. So here's my big picture. We have structural and systemic health disparities that we see. They are sturdy, they are difficult to ameliorate. And the way that these sort of filter down is through less access to and representation in research, which results in less knowledge or utility for research, a mistrust or a distrust of researchers in the healthcare system, worse health behaviors, and less benefit from new cutting-edge solutions. And all of those things create suboptimal healthcare, higher risk for illness and disease, more severe illness and disease, premature mortality, filtering back up and replicating those disparities. Um, and I think that's important to think about this framing because often when we think about structures and systemic things, we think about policy, we think about Washington, we think about distribution of wealth, we think about things that are kind of outside of our control. But most of us here are a part of systems that design and deliver healthcare. And we have a part to play in this. And I think a lot of that is played out through our use of digital tools. So why texting? I'm going to be featuring a lot of work that I've done with my like right-hand person, Lindsay Nelson. So this is her. She works here at Vanderbilt with me, and she has really done some great work that I'm going to be featuring on disparities in digital tool use. So we know that there's been a significant rise in digital technologies for chronic disease self-management. We see frequent contact with patients via these digital tools. So people who don't have access to them get less frequent contact, timely dissemination of health information, self-monitoring and feedback with like timely tips, tailored self-management support, and new treatments and solution. In the diabetes space where we sit, the most important new treatments and solutions that we're seeing are CGM, continuous glucose monitors, and that is a very tech-heavy solution, requiring some smartphone savviness. It's also a very effective solution, and so making sure people can access and use that is really critical. But we know that rates of smartphone ownership and broadband subscription vary across groups, including household income and education. And every time I talk about this, I pull a new figure from Pew Research, but they've been basically the same figures for the last 15 years that I've been doing this work, which just says, yes, smartphone ownership is increasing, broadband ownership or access is increasing, but we still see variability by socioeconomic indicators and education. But there's also this idea that access or ownership of a device is not enough. Digital readiness is a confluence of factors, and three of the groups that make up about half of our population of adults are considered relatively hesitant, as compared to two groups that are characterized as more prepared. And you can see along the right here that the relatively hesitant have lower household incomes, less education, they're older, they're more likely to be from minoritized racial or ethnic groups. We also know from our work in diabetes that disparities in digital health related use lag disparities in access. So we did this study, we did a couple of studies, and we asked in all of our studies about smartphone ownership, health app use, all these sorts of things. And then we were able to sort of map over time. And we saw that the same disparities we saw in smartphone ownership in 2017 and 2018 in like very diverse patient populations we were recruiting for our studies. We saw those same disparities in health app use in 2021 and 2020, which basically, so like people got smartphones, but then they still weren't using them in all of the ways. And so I think that there's this mindset I hear where it's like, well, smartphone ownership is ubiquitous, so let's put everything on the patient portal, or let's do everything with an app. And that is not what we're seeing when we think about how people are actually using their smartphones. We also know that digital literacy, health literacy scores, and Dr. Lyles has done a lot of work in this space. There's this idea of like your familiarity and your confidence in using digital tools. A lot of this work has focused on using digital tools for health, but we also know in some of our political science space that ability to sort of navigate and find valid and trustworthy information on the internet mirrors this. And so this is not just a health crisis, it's kind of a national crisis that we need to pay attention to. So, we kind of knew all this, and it's not like these are new ideas that there's digital divide. We've talked about this for a long time, but one of my favorite articles in a long time was published by Jessica Onker and Tiffany Vino, and talks about how an intervention is actually producing inequality if it is more accessible to, adopted more frequently by, adhered more closely by, or more effective in advantaged groups. And while we know this and understand it, there is a bias and a bent towards using secure, more technologically advanced solutions for healthcare delivery. And so COVID-19 happened, and we got to see this kind of play out in real time. We understood that people's understanding of COVID and their access to vaccines was affecting the impact of COVID on themselves and on their communities. We also had to shift to telehealth and telemedicine. And this article in the New England Journal Catalyst, and it's funny because I've been talking about this for a while, and I realized Courtney is a co-author on this. Um, right before I was like, oh, wait a minute, she could probably tell this better than I could. But this group did work out of UCSF, General Internal Medicine Primary Care Practice, and they saw that telehealth increased patient visits for non-Hispanic white patients in the top line, but decreased telehealth visit or decreased patient visits for Black, Latino, Asian Pacific Islander participants. Or I'm sorry, patients, not participants. But then, not that much later, this article came out in JAMIA with Campos, Castile, and Anthony, and they kind of showed the opposite thing. They saw that Black, Latino, and other race patients had higher rates of telehealth use than non-Hispanic whites. So, which one is it? Are minoritized groups more likely to use telehealth or less likely to use telehealth? What might differentiate these two findings? It turns out that the first study was under the more traditional limited definition of telehealth that has to do with synchronous visits, video visits, visits on a telehealth platform. This study looks at telehealth after the definition was expanded during COVID to include phone calls and asynchronous text-only communications. So when we allowed for these more basic technologies, we saw kind of an inverse effect on an inverse disparity on telehealth use. So this presents an opportunity. The broader definition adopted during COVID-19 shows us that we can think about design of telehealth to actually reduce disparities. But what happened? We went back, right, to the definition before COVID. And so this begs the question of who are we designing telehealth for? And I don't necessarily mean we're designing it for white people with resources. I mean, we're designing it for the healthcare system. We're designing it this way because it's better, it's easier for billing, it's less risky because we think we can provide higher quality care through this process. So, it's also easier to track, like when you've had a visit versus not, and it segments the time more nicely. And so we've kind of created a system that's based on billing and not really thinking about what we've learned about our ability to actually increase access to healthcare by expanding to other forms of communication. And this is just sort of a microcosm to me of the way that we are kind of pushing some of our intervention design to. So I push for texting and phone calls. I'm talking to you today about texting and phone calls because of these disparities in access. We know that access does not equal use. So just because you have something doesn't mean you can use it to improve your health. And, when we use websites and apps, we are leaving out people who are not already engaged in their health and health behaviors with overlapping vulnerabilities and competing demands and who have worse health behaviors and health outcomes. We as the healthcare provider or as the researcher can often provide a lot more complete and rigorous information to them and feel better about the service that we're providing. But we are sort of been demonstrated time and time again, replicating those inequalities with our interventions. Also, text messaging just works. I'm not gonna, there's so many systematic reviews on this, but it has hit the level of being recommendations, started in 2014 by the US Department of Health and Human Services, in 2016, the World Health Organization, and then in 2021, 2024, the American Diabetes Association specifically says that there's evidence to suggest that standard of care would combine a digital technology and a human component, and specifically text messaging. So we have a body of evidence that tells us this is the way to reach people to improve public health. Also, we know that these theoretical models have shown that technology, when it's done right, especially when it's combined with a trusted human relationship, so like your physician, a nurse, the researcher assistant who enrolled you in the study, an interventionist, a diabetes educator. When you combine those things, you create this kind of magical psychological phenomenon with the technology where the technology is seen as an invisible, benevolent coach who is trustworthy, cares about them. And even when we sort of tell people this is a computer, it's automated, they still report feeling cared about, feeling accountable, wanting to let people know how they're doing, feeling like their clinic values them more, even if the study, is separate from their clinic. We get this sort of social support impact when we can do good technology delivered interventions to folks. It also helps identify and address participants who need additional support or might be experiencing multiple barriers. Technology is really effective. Text messaging technology is really effective at helping us say who needs more help and then providing targeted support versus a lot of the web-based platforms are like, the support is here, you can come to it if you'd like. And that is where we see the sort of the people who are already doing well seek it out. Whereas texting can help us identify folks and then provide targeted support. We also have seen that it enhances patient engagement in research and in their own health behaviors. It also can help us apply evidence-based behavior change techniques that other technologies cannot help us provide. So behavioral nudges, monitoring and feedback, tailored content to overcome personalized barriers. And you might say, apps can do that, and they absolutely can. Apps can do that. But there's some important design differences between apps versus text messaging that has to do with how much information do you need them to get in a short period of time versus is this a behavior you need for them to maintain over time? So if you want somebody to go get a vaccination, that's a really nice opportunity for a targeted, a tailored interactive app experience where they leave and they think about it. Maybe they decide to go get the vaccination. However, if you're trying to get them to adhere to their medications, that's repeated behavior over time. We're trying to do habit formation. That is not something that we can see effectively improved with app use because app use tends to fall off after the first couple months. So thinking about what type of engagement do you need for the behavior that you're trying to change? And then there's this idea of something that's pushing them to the technology versus the technology pulling them in. So apps are really effective for folks who are, let's say, going through pregnancy and they have questions and they want information. So they're being pushed by the changes in their body to go seek out information about their pregnancy. If somebody's having a migraine and they can go seek out pain relief techniques that they could try while they're having their migraine, there's something happening in the person's sort of experience that pushes them to the technology, as opposed to I'm not paying attention to my diabetes management. I'm ignoring it. You need a technology that's going to reach out and activate them and pull them in. And so trying to engage people who are disengaged with an app has not been effective. Even though the technology is better in some ways, it doesn't seem to strike that engagement for certain use cases. This behavior change wheel, this is just sort of a theory that I have been talking around is like what behavior change techniques are needed for this behavior, and then what modalities or what aspects of the digital tool, what functionality matches with that best. And so I think it's important for us to sort of make the point that whenever I present on my text messaging work, people say, is your next step an app? And it's not a continuum from texting to app to patient portal, but rather each of these tools has different roles to play. And we have to be mindful about what are we trying to do and which technology best has functionality to do that thing to change that behavior. All right, so I'm going to talk to you about some examples of texting solutions from our work to illustrate some of the concepts that we've talked about. So this is a kind of an old study now, although it's only a few years ago. It feels like lifetimes ago. So we did a study called REACH where we recruited over 500 adults with type 2 diabetes. And what was exciting about this study is that about half were recruited from federally qualified health centers, and we were like all over Middle Tennessee. We had 53% minoritized race and ethnicity. Over 56% had annual household incomes less than 35,000, half were underinsured, and about 12% of the sample were homeless. And we were so successful with this study given our sample. We had a control group that got free A1C tests every 3 months, and we would text message them when the results were ready, and they could call us to see it, or they could like authenticate and get the result. They also had access to a helpline where they could call and ask questions of a clinical pharmacist about their medications. And then the REACH group got all of that plus daily self-care text messages. And then the Reach Plus FAMS group got all of that, plus monthly phone coaching and the option to invite a friend or family member to receive text messages to sort of provide more support to them. So the 3-arm trial for 12 months, actually 15 months, sorry. But the 12-month, it was a 12-month intervention and 3-month sustainability phase. So over 12 months, our response rate to daily interactive text was median 91%. I don't know what else to say about that. That's just like unheard of. I don't think we would necessarily get that high of engagement with text messaging today if we did the exact same study the exact same way, because word has gotten out about texting and people are sort of flooded with political texts and spamming texts. But I think what this is saying is that this modality can be incredibly effective at engaging people when it's done well. And after 6 months, we asked folks, we were afraid that they would be annoyed by the text messages and we wanted to make sure we could keep them in. So after 6 months, we asked them, do you want to continue daily interactive text? And half the person said yes, they did. Over 90% completed at least 2/3 of the monthly coaching calls that happened just via phone. There was no telehealth component. And we retained 85% or more at each time point through 15 months. We did see adherence improvements and clinically meaningful A1C reductions. One of the things that's most interesting here, and this gets to that push versus pull thing I was talking about, is that we offered this helpline to speak to a clinical pharmacist. It was a lot of work. It had to be like HIPAA secure. We paid a bunch of money for it, and it was offered to everybody. And so across 512 people, only 5 of them called for the whole study period. And so I think it's a good example of how even when you're using a basic phone technology that people have access to, the onus being on them to reach out for the help creates a completely different dynamic than the text messages that would reach out and check in with them and they were interacting with. Also, a great control group, if you're designing a study, is to give people access to a helpline because they're really excited about it when they're told about it. And then it's like the most low demand thing. Just don't make it HIPAA secure and pay a server fee like we did. And this thing has legs. There's a endocrinologist that's a training of mine that has developed Reach Espanol, which is culturally tailored and it's all in Spanish. And she's just finishing a pilot study where she's seen similar levels of engagement and enthusiasm from that sample. So it's continuing to live on, but we were not able to implement it in the clinics because of some of the roadblocks I'm going to talk to you about. So we pursued implementation funding for this and never could get through the red tape and the perception that texting was not an acceptable thing for us to implement in clinical care. So then one of the uses we're doing now is a study called Precedented. So this is a PCORI funded study it's a clinical comparative effectiveness study that's comparing GLP-1 receptor agonists with SGLT2 inhibitors. GLP-1s are much in the news, Ozempic, Wegovy, those are the names of that. They're linked with weight loss, but what is really important for us is that they have demonstrated, both classes of medication have demonstrated prevention of cardiometabolic and kidney disease outcomes in people with type 2 diabetes. So the question is, which is better and for whom? And so in the study design, it's a very unique study because patients, if they are randomized, they're randomized to one of the study medication groups, but then the study site's doctor prescribes it and they cover it with their regular medical insurance. So they're not provided with study med. And that is largely because pharmaceutical companies are not super interested in comparing their meds with other pharmaceutical companies' meds. There's not a lot of incentive there. So precedent is very unique. And can we really partner with patients to answer questions like this when we can't provide med? So patients have to pick up their medicine at their usual pharmacy, pay their copay or percentage that they would pay, and then take it for the next few years. They have to pick up refills and then complete in-person clinic visits and answer questions every 6 months. Um, so this is a challenging study. Um, they have to pay for the meds, and study compensation is like $500 a year, which is a lot, but it sometimes doesn't cover the cost of the meds. The cost of the meds, the availability of the meds, and people's insurance coverage is changing a lot. Side effects of these meds are common and must be managed by the clinical care team for the participant to keep taking the medication. And we are following them for up to 5 years, so it's not like a short-term commitment. So we're asking a lot. And in our work, I lead the engagement work for this study. And in our work with participants about our patients about how do we best design, it was clear that they wanted to know that we value their contributions. They wanted to know how to get help navigating barriers, and they want us to just check in with them to demonstrate care and value of their time, effort, and energy. And that's difficult to do because there's going to be 6,000 patients over like 20 sites, or 40 sites, actually. We have 40 sites now. And the refills are every 90 days. So that's too much work for one person to do. And we can't expect the sites to do that work. And so we had this question of how do we support participants to take the study meds? And so based on our prior work in digital tool development, we did a co-design process with the president study team, including myself and Lindsay Nelson. We applied our best practices in digital health tool design. Memotex is our technology partner, and they built the program to interface with REDCap for the data coordinating center so that all of the sites could input information and it would communicate with Memotex. And then our patient partners identified the program goals, co-write our message content, and helped us complete beta testing and give feedback on the system. So this is kind of what the timeline looks in. We developed a welcome text, an initial fill message to say, like, are you having problems starting the med? And then we have med check-in messages every 3 months. And then we also have these timeline anchoring messages in green that help people know where they are in the study and what to expect. Are they getting a survey? Is there a clinic visit? Like sort of what's happening. So these are example messages, provides them with ways to get in touch with the study team via call or text. And the study timeline reminders have a message about, what's going to happen this month. Also, there's a message about the value of their contribution that our patient partners wrote, and they're different for each timeline anchoring that talks about how important it is or how long they've been in the study and how important their contributions are. And then we have this message flow where we say, have you started taking your new study medication, Jardiance? And if they have not, then somebody from the team reaches out to them to help troubleshoot. And then every 3 months, the med check-in does something similar. Are you still taking it? And if not, tell us why, and then somebody will reach out. This mirrors the interactive messages we used in Reach that had high response rates to. The ones in Reach were daily about did you take your meds, but the flow is very similar. And here we're asking about refill adherence. So in the first year, 450 participants across 20 sites got the messages. You can see the characteristics of the study sample. Our goal was to engage and retain participants, and then also to identify participants needing assistance. So for our first goal of engaging and retaining participants, we sent about 1,000 interactive messages, and 80% of those received a response. We were more successful with the adherence messages than the initial fill message. Only 41 responses were unsolicited. So this was participants who would text help like randomly when they just had a problem, and that was their way of getting in touch with the study team. And we told participants at the beginning that they could text stop if they wanted to stop receiving the messages, and no participants texted stop. I think that's important because whenever you design these programs with scientists and doctors, they say this is annoying. This is going to annoy people. They're going to hate it. And that's just really not our experience when we deploy these tools. Um, our second goal of identifying participants needing assistance obtaining and adhering to study meds. 25% of our interactive messages indicated problems, prompting outreach from the coordinating center. 88% were because their responses indicated problems. The remaining 12% were because they were non-responsive to the messages. And so the coordinating center would call them to check in. We identified problems with trouble getting fills and refills, experiencing a health concern or side effect, and then having questions about the study. So in terms of workload, we dramatically reduced calls from, you know, thousands of calls down to about 112 calls in a year, or I guess it's more like 130 calls in a year from the coordinating center. So we feel like we have some evidence that this tool performs well in the context of a larger comparative effectiveness study. One more example is a trainee of mine, Kristen Fritz, has been working to make food resources available for families who screen positive for food insecurity when their child is hospitalized. And so the sort of state of the art at the time was that they would get printed materials with their discharge papers, and those printed materials were not tailored to where they lived. So we at Vanderbilt, and I'm sure at other health systems, have people that travel from other states and, hours away for care, particularly for our children's hospital. And we would give them resources about the Nashville area, and that wasn't necessarily super helpful. And also, I have definitely been discharged from the hospital before, and the pile of papers they give me ends up on the front floorboard of my car. And I know that that makes physicians shudder, but it's true. And so I think, her idea was, how do we provide proactive outreach that gives a resource that is tailored to their zip code, and that is not the day that they're going home from the hospital, but can follow them for the few days after. So she developed this resource that leverages other existing, uh, I'm blanking on the name of it right now. It used to be called Aunt Bertha, where there's existing places where you can go and enter a zip code and get all of these resources. And so she's leveraging that tool and connecting it with a REDCap interface so that she can sort of click track, but also provide follow-up. So people get the message when they're discharged from the hospital, they get it again a week later. Oops, sorry. And she did a pilot, and 103 families were screened for positive for food insecurity. She found that her text messages successfully reached 92%. 35% clicked the Find Help link, and 49% responded to follow-up messages. 91% said they used the message, and 44% said, they read the message, and 44% used it to search for resources. So the next steps for her is she just completed a pragmatic randomized trial with 600 families. She's looking to determine efficacy in connecting them to food resources from this new tool. So that is a really exciting one for me because it's one of the only ones where we've seen a texting solution actually break through into clinical care. Sometimes these things are a lot easier in the pediatric space to get through than in the adult space for reasons I don't completely understand, but we're really excited about this work. So now I'm going to talk to you about roadblocks and solutions to getting these sort of, I feel like our engagement data is really strong. I feel like our reach to populations that we know are not reached by telehealth and patient portals is really strong. But when we try to move some of these things into clinical care or into implementation, we have hit repeated roadblocks. So I'm going to talk to you about those. So not so long ago, CMS changed some of their guidelines for texting, and there's this threat that if you violate CMS guidelines, you don't get funding for Medicaid, Medicare, and that puts a lot of health systems into a little bit of panic where they want to shut down anything and then take time to sort of assess if it's in violation or not. We also have, HIPAA, patient privacy concerns from institutions happening at the same time that we're seeing a lot of data breaches or data leaks, and that affects institutional reputation. Phishing and ransomware attacks are constantly happening. So there's like a shutdown happening where um, we want to make sure that anything that is any way interfacing with our networks is fully secure and vetted so that if we do have a phishing or ransomware attack, that they don't have access, we sort of limit the scope of the impact of that. There's also Epic, the medical record, has been sort of under the radar, putting forth a very systematic campaign against anything that has to do with loosening privacy constraints in order to increase access. And a lot of that has to do with ownership of the data and ownership over the ability to innovate with the data. And in doing so, things happen that maybe people don't completely think through in terms of their impact on downstream opportunities to do public health work. Um, Data breaches and institutional, oh wait, I already said that, sorry. Government and political concerns about foreign countries' access. So a lot of the times when you're building these technology systems, you don't even realize that the data goes through a server in Canada, and that creates a whole bunch of stress and strife as our government gets nervous about those sorts of things. Um, Health IT restrictions and increased security measures, the vetting process for technology solutions has increased dramatically in terms of the number of offices that need to touch it and the number of things they need to assess. So all of these things combined with the perception of folks like you and me that texts are annoying because we sit in front of computers and get emails all day, and maybe we're on a bunch of political lists, and maybe we get pinged all the day on the medical record as we're doing our clinical work. And we think this is just a bad idea to begin with, and it's not secure or safe. So maybe you should just use the patient portal. We've set that up, we vetted it. Just why can't you just do the portal, do what you want to do with the portal? And also, doesn't everyone have a smartphone anyway? Can't you just pivot to an app? I don't understand why you're fighting. Like, why are you giving me a headache, right? And so it's like all of these sort of institutional concerns combined with the bias or the bent towards let's just use the tools we have that we know are secure and the tools that I would prefer. Create this sort of situation where it's really difficult to get these things through. So why is this a problem? Text cannot be encrypted, which is inconsistent with HIPAA guidance for PHI. HIPAA encryptions are expensive and kind of nonsensical. A lot of places will tell you, oh, you can pay us $2,000 a month for HIPAA security, and your institution will say, yes, do that, that will work, but you can't actually encrypt a text message. So unless you use a web-based system. So, we're sort of developing workarounds that aren't real workarounds there. There's also a misapplication of PHI guidance, which I think we want to think really carefully about. This gets back to the epic lobbying question of like, is everything that lives in the medical record subject to the same rules as clinical care encounter data? As we're collecting health-related social needs data from people using the epic, what do you call it, form or whatever, there's a better word for it. But that's being rolled out a lot of places. So as we store more and more things in the medical record, does that make it PHI? Or should we be able to use some things that aren't generated through billable clinical care encounters for other purposes? And can a patient provide their health data to a self-care or support program? Can they allow for their PHI or their to be used? Those are questions that are literally being like our legal teams are saying no, they're not allowed to give permission for their data to be used. The protective demands that are being placed, I think, are reducing our impact and kind of, make the interventions kind of impotent. So they'll say you have to separately consent people about text messages, or you have to say that the research can't require texting, which violates the principles of randomization and really sort of cuts us off at the knees in a lot of cases. They say, well, let's just use a web app, but that has all of the same barriers as app use, sort of replicates that. And then there's all the different types of phones, and the way the web app works with all the different types of phones can be a major headache. One other thing I'll say about this is they say, why don't you just text them a web link, and then they can click on the web link and read the content. Luckily, we had data on this. So this was in our most recent RCT that we've completed. We had a median text response rate of 82%. So daily text messages, 82% got a response. The same people over the same period of time were also texted web links, and only 24% of the text that contained a web link were clicked. Same people, same time period. They're just not taking that extra step to click the web link. So if we go from texting to texting web links, this is our sort of potency fall off. So I'm running out of time and I want to get to usability, user-centered design, but I think my big picture message is like thinking about when we think about patient privacy and security and risk, who is really being protected by those terms? And how do we use ubiquitous technology and engaging technology to enhance engagement in research, participation in research, participation in healthcare, participation in health behaviors in order to do a better job with that flow chart from sort of systemic inequity down to health disparities? Um, and how do we think about the reach and impact of public health efforts, not the same way as clinical care work? I think that we have institutional requirements. If we're going to move into collecting things like health-related social needs, there's a demand on us to think about what policies apply to clinical care encounters and PHI and things that are billable to insurance, and what policies and guidelines we need to be developing for public health work with data that also lives in the medical record. So in 5 minutes, I'm going to tell you how to do this well. Choose tech that's already used by disadvantaged and at-risk groups. Select evidence-based design elements for reaching and engaging those groups specifically. This is, with health literacy, we say, well, oh, we'll design different interventions for people with limited health literacy. It's like, no, that doesn't work. You design everything for people with limited health literacy, and then everyone benefits. It's the same idea in terms of technology access and use. If you design an intervention that's engaging to people who are at risk for worse outcomes, everybody will benefit. And so including those patients in the design process and in usability testing can help ensure that that will be the case. And then my fourth one is invest in build costs or partner with technology companies. So this review, a little bit dated now, but they said that the most commonly reported facilitator of intervention success was use of tech participants were already familiar with, and that when studies would provide iPads, the provision of the iPad didn't result in like use. And so using something that people are already using in their daily lives was the most commonly reported facilitator. And we have some guidance that's coming out in medical care article on the precedent study about what are these evidence-based design elements. But essentially, we want to think about the patient as a person over time rather than thinking about like an appointment, like a visit, like event-centric design. So thinking about how do we design for an individual as they change over time. Interactive messages, algorithms that provide feedback to them that are very chatty, use first names, smiley faces, don't sound like a computer, tailor to people's personal schedules, accommodate shift work, use their name and pronouns, their medication regimen, their own personal goals, giving tailored feedback on their progress each week, updating over time. That's part of that seeing a person over time. And then considering option to choose message frequency because daily messages work for some folks, but not for all. One of the things that's been most important learning in our work with our patient partners is the content must be positive, affirming, and encouraging, and cannot appear to imply that they're struggling or having problems. So that is a challenge because a lot of time our message content want to say like, if you're feeling like overwhelmed by your diabetes, do this. And people say the feeling of like existing in your day and you're like killing it. And then you get a message that's like, if you're feeling overwhelmed by diabetes is a real buzzkill. And like, let's not do that. And so finding ways to give the same information without assuming a deficit or a problem has been an important challenge. There's a lot of work on best practices for effective health communication to follow, and then designing for people with limited health literacy. And then the other thing is just including a human component where you can build trust. That can be an existing relationship that the platform is leveraged off of, or you can bring in a coach or a health navigator or even study staff. And then adding the option to invite a friend or family member. This is one of those places too, we've seen reverse disparity where people who are with characteristics that would indicate they're at risk for worse outcomes are also more likely to engage a support person with technology. And so making those options available, if it's a patient portal delegate, if it's, whatever it might be, designing for that from the beginning and rather than it being an afterthought. Step 3, including patients that represent those at-risk groups in your design and usability testing. This is a great method that we've used that brings patients to the table with the technology design person and the clinician and the researcher to say, what are we trying to solve for and what might it look like? And everybody sort of sketches out prototypes and then you pick your favorite prototypes. It's a really great way to quickly do some design work that makes patients an equal partner in the design process. Community engagement studios or focus groups to review the content and functionality. Ask them what's wrong or what's missing with this design and how might this fail. Jackie, one of my mentees, did this really cool thing when she was translating the messages from English into Spanish, where she had native Spanish speakers from different countries come and she gave them paddles and she would put each message up and they would say, see if they liked it, it made sense to them, or no, if it didn't. And they were able to sort of see which messages made sense to which native speakers from where and which not, and discuss why. And it was a really cool way to rapidly evaluate the translation of the text messaging. Usability testing is our go-to. You do 3 rounds with target users. You can do real world testing where they go out and use it and then come back and tell you, or you can bring them into a session and have them use it in the moment and think through it and tell you what their experiences of it is. Best practices are always to collect qualitative and quantitative data and objective and subjective data about their experience. Like how often are they engaging? Where are they clicking? How many minutes does it take them? But also how do they feel about the experience? This is Chris is a group we have here that really specializes in this, and they have some stuff on their website about usability testing design in case people need more resources. And then I think it's really important to invest in build costs or partner with technology companies. There's pros and cons to each. I partner with industry. It's an uphill battle at first for them to go through the approvals process and like sort of form the relationship, but it's much quicker once your thing is sort of built. It's much quicker to edit it and then deploy it and make it live out in the world. The downside is they can break up with you if your idea is not in their product roadmap, which has happened to me. But they also are already thinking about how to integrate AI and how to integrate human components, and they have ideas and built out solutions that you may not have thought of yet. And it really aids in future iterations and commercialization. We worked with Mimotext, our partner, to co-commercialize Reach. So like you could go on their website and like buy it and like use it in your health system. And so I'm not heavily involved in that. Like if somebody wants to buy it, I can consult with them, but like it's a nice way for the tool to actually go have a life while you keep doing your career. Um, with RedCap though, you can do this with as long as you budget for increased development costs and make sure that your research team is budgeted to monitor the tool more closely. There are no institutional fights here. There's no contracting, there's no data use agreements. If you're, people trust it. It's hard to make sure that your developer can actually do what you need until you're too far down the pike, and then you just have to change your design because you don't have another developer. Build time takes longer, and when the study ends, the program is done. And when they update REDCap, sometimes everything goes into disarray. So, I think it's pros and cons, and it depends on like, is it a small project? Is it a startup project, or is this like something that you're going to sort of see through long term as to which one is the right way to go? Same as the costs, essentially your level of control, the data availability to you, and integration with the study data. All that I think is the same regardless of which way you go. Okay, so I'm back here to say to you this. Um, when when we think of things like systemic racism or unequal distribution of resources, we are actually in positions of power to address the root causes of disparities when it comes to how we think about designing and using technology, because as we do work to improve health, we are necessarily either replicating and exacerbating existing inequities or seeking to ameliorate those. And it doesn't matter if you're doing disparities work or not doing disparities work. We are all always doing disparities work when we are in the space of technology development and intervention delivery. And so I think just owning that, and even though I came into this field to do work in family, if I want to do family among people who are struggling with diabetes management, I'm kind of in the disparities technology space. And I would say that we kind of all are, and we have to think about how we can push our institutions to develop better policies that think about things in this way. So that's it. Advocate for broad definitions of telehealth if that's your domain. Courtney has done amazing work in that space. Advocate for use of texting and research and health promotion programs, public health program, design policies that differentiate, help us tease apart when is it clinical care encounter data and when is it something else that needs to be used in other ways. These are my people. I apparently didn't write Jacqueline's full name, but Jacqueline Segley is in that list too. And these are our clinic partners for the REACH study. And I'm happy to take your questions.
So amazing. Thank you so much.
Thank you.
Lindsay, you covered policy and like IRB push. I loved everything about it. So I do have, I mean, obviously I'm very biased in my own research profile. I have questions for Lindsay, but I'm going to pause and see if anybody wants to raise their hand or put something in the chat. I answered one thing in the chat
Yes, thank you.
for you. It's called Find Help.
Thank you.
Um, any questions before I dive in? I'm going to talk slowly. My question, so I'll get us started, and then I think sometimes people warm up, which is that I just love that you're advocating for change. So one comment, I guess I hate to be the person who says comment, a question is, our IRB is pushing back, but it sounds not as hard as yours on the HIPAA compliance with text messaging. So now I'm like nervous about all my future studies. We've been able to get text message content through and not separate consent forms for text messaging. One of the issues that has come up from us is that the FTC is changing, like the blocking of text messages that come from our study numbers and getting registered numbers
Yeah.
versus unregistered
Yes.
numbers. So that's another issue that I know is like interrelated, but we still have been able to navigate it. I I guess as an academic, it was so interesting you went there. As an academic, how do you think we should be communicating about the types of interventions that are most effective? You have a lot of great data, but what are other strategies you would recommend for us? Because it's like those are the things we don't put in our papers. Like how, like I feel like we put the main result, but then how many people didn't open a web link or how many people didn't go to the next thing? Like, it sounds like you're culling that data and trying to push it out there. Have you thought about other activities in that space specifically that we could get behind, not just text messaging, but things that work, things that are working for
Yeah.
participants that we need to really talk more about.
I will tell you that a lot of the IRB stuff I didn't mention isn't my institution either. It's when I have had multi-site studies that we've been up against it, where and one of the recommendations I skipped over because I was long-winded and wanted to leave time for discussion was that we need trans-institutional guidance about these sorts of things the same way we have like a single IRB. Like we need a reliance agreement for tech solutions or something, because navigating the same questions and slightly different interpretations for multi-site trials has been where these things have come up for me. And so the way that I have been going about this, and I'm not saying it's the only way, is number one is like I roadshow like this. This is the third place I've talked to about this issue, fourth place talk to about this issue. And I think part of it is just awareness. If you're not doing work exactly in this space, you don't really realize that it's being kind of pushed out. And the other thing is that I have bbeen trying to lobby within my funders. So like NIDDK, I've been pushing them on their implementation science stuff. And then, and I'm with PCORI, I do a lot of work with PCORI. And so I'm trying to push PCOR Net to have some institutional policies around like texting solutions and stuff, because it's really difficult to do clinical comparative effectiveness research without those forms of outreach. and they're always multi-site studies. And so that's how I've been going about it. I'm a researcher. I'm too busy doing research to go do policy. And that's why talk like this to try to encourage those of us in the world that are good and savvy with policy to maybe take this as a pet project and help push it forward. I really think that my belief in general across the board is that people want to do the right thing most of the time. And just putting it in front of them and being redundant about it has gotten us a lot of traction here. And so, yeah, I'm sure there are better solutions.
I don't know, but now you're making me, maybe we could write something together. Maybe we should think about some of the data that we have that
Yeah.
we could pull out and do something because yeah, I agree. The only other question I saw in the chat, but if anybody wants to raise their hand, I think we could squeeze one more in, is you talked about a lot of things that from the policy or structural that didn't work. Someone was asking, are there other roadblocks or challenges that you didn't get to mention that you think would be important for people, maybe even on the behavioral science domain or any of the other domains that you're such an expert in that you wanted to share with the group?
I think that everybody in whenever you go up for grant review, people say texting isn't innovative, and you're like, I'm not that's not the point. That's not what and so I think that there's a push for us to make it in a natural language model and make it AI. And I think that's an important thing for people to go in with eyes wide open is like, is the goal here to innovate with the technology, or is the goal to use an engaging technology to innovate in another space or to address another broader issue? I think that that's something that's really important to tease apart. And it's not just text messaging for texting's sake. It's to say like it's been effective in this behavior or this outcome or this group. That type of communication is really important. And then what you talked about with having to register your number and numbers being blocked, and like using texting for outreach to study participants about communicating about scheduling their study visit is different. It's
Mhm.
treated differently and it is different than texting for like public health campaigns, or intervention delivery. And so making sure that you are clear about those use cases and because they have their own sort of requirements and problems.
Such an expert. I love text message research. You're just like speaking to me today. I have two other studies, so maybe I need to take you out to lunch and pick your brain and
Yeah.
tell you about. We have hypertension studies, two huge ones happening with text, so I would love to talk to you about them at a different time. I don't think we have any other questions from the audience, but we had a great group today. We just really, really appreciate you taking the time. I just love that you combine so many fields, that you took your background in behavioral science and family and community context, and informatics came to you, and you just have gone all the way in. I just think that's a great lesson for everyone
Thank you.
here is to just dive in and to really make change where you can and all equity centered. So appreciate you, Lindsay. Really appreciate all your words. And Pete, you left your email up there in case anybody wanted
Yeah,
to.
and I'm happy to come give you my family talk if you ever want
I
it.
would love, okay, great, great. I would love to
It
know
might not
family,
be great for
how to
this
engage a
group,
family.
but yeah, there's a lot of cool stuff happening in family science with text messaging is just the backdrop, but like, you know what I
I would
mean?
love to have
So
that. Maybe
that's
I need
fun.
to have you and come
Yeah,
and do that one.
that'd be great.
Amazing. Great to
All
see
right,
you. Great that everyone for coming and have a great afternoon. Thank
thanks.
you all.